All right, guys, as promised, I'm here. Okay, so let's see if we can get a request in. Hold on. Michael, if you can send me a request on your end, I'll see if I can get you in. Hold on, stand by. Got it. Okay.
All right, here we go.
Hello. Can you hear me okay?
Yep. Sounds
All
good.
right, good. Nice to see you. We made it happen, which is
Yeah,
fantastic.
awesome.
So why don't you introduce yourself and
Sure.
tell my followers a little bit about yourself.
Oh, well, first off, thank you for inviting me to talk to your followers. So I'm Dr. Michael Twyman. I'm a heart attack prevention expert, and I'm the biohacking cardiologist. That's the reason for these classes, which maybe we'll get into today. I now focus on heart attack and stroke prevention. I'm a conventionally trained cardiologist here at St. Louis University. And about 7 years ago, went down the rabbit hole of functional medicine and have been working on getting to the root cause of people's vascular disease since that point. And then in August, I left the previous group and started my own solo group so I can exclusively focus on outpatient care.
Amazing. So I want to point out to everyone who's listening, he's actually a real cardiologist.
Yes.
You did a traditional cardiology training. Did you do a fellowship as well?
I did. So I did 3 years of internal medicine, did 4 years in the Navy as an internist, then went back to cardiology for 3 years.
Okay.
And I've been practiced for 7 years as a cardiologist.
Incredible. So that's important for my listeners. I always like to make sure that we validate the source. So you're a great source, highly educated, and you've had clinical experience. 3 years in the Navy, I didn't know that. So now the connection between Task Force Dagger all makes sense. So as you guys all know, my husband's a Navy SEAL, and I work with a lot of the special operations community. And obviously you have too. So that's incredible. So I'm here taking some notes. That way, if people have questions for me, I'll do a nice summary and be really valuable, and then they'll know where to find you. So, you know, as I was going through the questions about this, I had a lot of people ask me about cholesterol. Sure. And I'd love for you to kind of explain to us how you explain to your patients the concept of cholesterol, the cholesterol when we're looking at blood work versus what we're making in our body. Just take us through it.
Okay, sure. So what I tell people is cholesterol is a very important substance. Every cell in your body needs cholesterol. So cholesterol wasn't put in you to give you heart attacks and strokes. And it's actually the inflammation in your system, your immune system turned on and staying on too long, that tends to damage the cholesterol. So it's the damaged cholesterol that tends to cause the plaque buildups in the arteries. So I tell patients, you know, cholesterol is, 70% of it or so is made in your liver. The rest of it comes in through your diet. And it's really what happens to that cholesterol when it's in your system that determines if you're developing plaque in the arteries. So cholesterol is a waxy substance. It's kind of like oil and vinegar. It won't float in the blood by itself. So there's these things called particles, or LDL particles, or like little cars or vans. Where I tell people it fills up with the cholesterol. Right. The LDL particles take it from your liver out to the cells, deliver the payload. The HDL particles tend to pick it up from the cells, bring it back to the liver for recycling. So it's more important to know how many particles you have floating around in your bloodstream than it is to know exactly how much cholesterol you have. And that can be obtained on, advanced blood work can be obtained that shows that particle number. And then also secondary is the particle size. That's important.
So when it comes to particle number, can you expand a little bit about that? You know, I'm sure people are going to be thinking about their blood work and, sure. At least my people.
Yeah, so particle number typically, depends what labs you're looking at, but about 1,000 is kind of the cutoff of, where you start considering maybe you should be doing something therapeutic from a lifestyle supplement standpoint to try to get under 1,000. If you have known vascular disease, meaning you've had a heart attack, you've had a stroke, you have a stent, or you have a really high CT coronary calcium score or calcium scan, then those people should probably have LDL particle numbers less than 1,000.
And that, the calcium scan, that's something really important to bring up because, you and I called you to consult on a patient, and you don't recommend that everybody gets a calcium scan. So it really depends on their age, right? Can you tell us a little bit more about that there may be validity if someone is older versus if someone is younger, that it's not necessarily predictive of any kind of upcoming event when they're younger?
Okay. So the CT coronary calcium score is a painless 5-minute CT scan that's looking for calcium in the walls of your heart arteries. Calcium is supposed to be in your bones and teeth. It's not supposed to be building up in the walls of the arteries. And the calcium scan, if it's 0, you're very low risk. Your quoted risk of a heart attack or stroke is 0.4% over 5 years. So the best people to get a calcium score are people who are generally asymptomatic and might be in the intermediate risk category. So the people who are high risk, they've already had a heart attack, they already have stents, they've already had bypass, they've already had a stroke. The calcium score test isn't for them. You're not going to get more information using it. And if somebody's 20 years old, the calcium score is highly likely to be 0. So it's kind of that sweet spot, probably 40 years old and above with maybe more than one risk factor. So high blood pressure, high blood sugar, family history. Those are the people that probably should consider getting it. It's not best used in people who are symptomatic. I'll sometimes still use it in symptomatic people to show that if their score is 0.
Can you explain why someone wouldn't use it if they were symptomatic?
Because if somebody's symptomatic, you need to kind of go to the more conventional side and make sure that it's not a severe stenosis or blockage in one of the 3 arteries that's causing those symptoms. So if somebody has chest pain, pressure with exercise, or shortness of breath, or they're just slowing down with their exercise, they probably need some type of supervised stress test to see, can you recreate those symptoms and find, do they have a severe blockage? And by severe blockage, typically it's a 70% or more blockage in one of the 3 arteries.
And so to recap, you said anyone really above 40 or with a risk factor, which would be high blood pressure, difficulty with blood sugar control, or a family history. Now, once you get that number, what is kind of like the number you're looking for in terms of what is the safe range versus when you start to get concerned?
So the safe range is optimally of 0. You want to be a 0 the rest of your life. And I've had patients.
Nobody wants 0 the rest of their life.
Yeah. And this is the only time you want to be a 0 is on your calcium score. But I've had patients up into their 80s with a calcium score of 0. So it does not mean you're automatically going to get a plaque in your arteries. But of all comers who do the score, 6 out of 10 people are going to have some calcium in the arteries. So typically tell patients, if your score is under 100, you're higher risk than 0, but not excessively, and probably still work mostly with your lifestyle, supplements, and meds if you have a lot of other risk factors. 100, 400, even the new standard cardiology guidelines say you should consider a statin for those people who can't improve with lifestyle. And then over 400, more likely.
Between 100 and 400, the conventional wisdom is to utilize a statin. Did I hear you correctly?
At least consider it. And then over 400, unless there's a strong indication not to, more likely than not, you're probably going to at least recommend a statin. And then using the advanced blood work, you can really kind of fine-tune which statin is probably best for that person. But statins, a whole nother conversation I'm sure we can have. But typically, I don't get concerned until the calcium score is well over 400. Over 400, you have a few percentage point chance that one of your 3 heart arteries is going to have a severe blockage. If you're not having symptoms, doesn't mean you necessarily need to go have an invasive procedure. You don't need a heart catheterization. But if you're over 400, typically you're going to end up doing a stress test, putting somebody on a treadmill and seeing, can you bring out any ischemia or areas of the heart that look like they're not getting enough blood flow when they're exercising. So you can kind of tell them what the risk is to keep going to the gym and exercise. Over 1,000, they're very high risk, and you're very concerned that they're going to have severe blockages. And almost everybody over 1,000 gets a heart catheterization to really kind of take a look at the arteries.
Yes. Lots of people in St. Louis do, for sure. So we both, just so you guys all know, we both trained. So I trained at WashU, and you were at SLU. Were you at St. Louis University?
Correct, I was.
And there's a high volume of patients, especially in cardiology and geriatrics, just the aging population. It's a very unhealthy part of the country, unfortunately. A lot of obesity, a lot of heart disease.
For sure.
So going back to so there's a particle and then there's LDL. So for a physician like me who's not a cardiologist, one of the things that I look at is I look at the advanced testing, and then I'll refer them out depending on if they're responsive to supplementation. It's really 50-50. And then there's the LDL, which the threshold, if you want to talk about it now, so for a traditionally trained physician, the threshold to offer a statin is an LDL of 190. That's kind of the guidelines. So I'm curious as to someone who has advanced training in cardiology, what is your kind of continuum in terms of how you determine when you initiate treatment, and if you're not going to utilize a statin, kind of some of your strategies for non-statin based therapies, and which individuals that you find are effective, or which non-statin based therapies are actually effective for individuals?
Okay, sure. We'll hit them all. So
Yeah, great.
typically the people that, who have LDLCs, and that's going to be on your standard lipid panel of 190, those people more likely than not have what's known as familial hyperlipidemia.
Right.
About 1% of the population has a gene where they don't make enough LDL receptors for whatever reason. There's 3 or 4 reasons why they might not. And so I tell patients the LDL receptor is like a little catcher's mitt that sits out on the side of your liver and is clearing the cholesterol from your bloodstream. And so if you don't have that receptor, your cholesterol levels just keep building up, building up, building up. And just it's kind of time under tension. So more particles and more cholesterol floating around the system, there's just more risk that stuff gets inflamed, gets damaged, and starts getting trapped in your arteries. So over 190, I'm almost always going to at least consider statin, but I will typically do some type of imaging test to tell me what is their vascular risk, because numbers on a page doesn't indicate who has plaque in their arteries. So people may know Bob Harper from The Biggest Loser. The guy looked super fit on the outside. He drops dead of a heart attack in the gym, gets resuscitated, gets stented. Well, he ended up having lipoprotein A, which is a type of cholesterol. If they didn't screen for that on the traditional panel, you're never going to know. But I'm sure if he would have had a calcium score, it probably would have been very elevated. So I typically will use the calcium score test and the blood work in correlation to say, okay, well, this person is more likely than not to benefit from statin. And then, typically on the blood work, people who say they can't tolerate statins, sometimes it's due to an ApoE gene. The people who have ApoE4s tend not to tolerate statins as much. But as you know, if you're vitamin D deficient, if your thyroid is underactive, you're more likely to get muscle pains from the statin. So I tend to use the water-based statins. I tend to use more pravastatin or rosuvastatin because they tend to cause a little bit less muscle pain in my experience.
And in terms of supplementation, why don't you tell us a little bit about the supplements that you utilize? I know that you've got some protocols that you found effective. I have a very low threshold for treatment. I really do think that in this world of kind of internet boom, there's all this information, and in terms of treatment, I have to see it work, right? So the initiation of treatment has to match the severity of the illness,
Correct.
So, I'm curious as to what your threshold for trialing. I know that you use fish oil, berberine. There's a whole slew of things that you use, and you found effective.
Correct. So, I'll work with the patient, to see if there's any other comorbidities that would, get kind of 2 birds with 1 stone. But, typically we'll recommend a lot of omega-3 supplementation. So it's the EPA and DHA component of the omega-3s that's useful for lowering LDL particle. It tends to make the LDL size, the real small, dense ones, bigger. And the bigger ones tend to not cause as much plaque formation. So I'll tend to use omega-3s almost in everybody for plaque stabilization if they have it.
And how high do you go in terms of dose for omega-3?
I would say typically goes a total of 4,000 milligrams, and usually divide that at least 2,000 milligrams twice a day.
Yep.
So a couple brands that I typically recommend.
Even if people don't have an issue.
Yeah,
so I'm anywhere, kind of up into that range.
Yeah, so high dose omega-3s. Yeah, I'll still use niacin on occasion, especially if they got high triglycerides or their HDL's low. But the data on the HDL raising isn't really that robust. It's much more about the LDL particles. So niacin can be used as a B vitamin. The challenge with niacin is it can cause a lot of flushing. There's pins and needle sensation at high doses. So many people can't tolerate the real high doses.
He loves it.
Yeah. Some people use it before they go in saunas to sweat it out and stuff. So, if you can tolerate the niacin, it's good. There's something called bergamot, which is essentially a citrus plant from Italy. The supplement form of it basically is a HMG-CoA reductase inhibitor. It blocks the same enzyme that the statins do, but tends not to cause the muscle aches. It doesn't deplete CoQ10. Doesn't cause the brain fog like some of the statins. So if patients can't tolerate statins or absolutely choose to prefer not to take them, I'll use bergamot as a trial. And then you mentioned berberine. Yeah. Berberine is another herb that will block cholesterol in the way similar to the, you might have heard of the injectable PCSK9 inhibitors. They're very expensive, once or twice a month injections. Those are very potent lowering agents for cholesterol. But berberine is essentially an oral PCSK9 inhibitor, much, much weaker than the injectables. Right. So basically it keeps that LDL receptor out there longer, that catchermet out there longer, clearing the cholesterol. Mm-hmm. But berberine is also useful for patients who are insulin resistant or pre-diabetic. Yes. So it's somewhat like metformin. So somebody doesn't want to take metformin or wants to do something different, berberine can help with glucose control, so I'll use it in that case. So those are probably the big four.
You find that the supplements actually, they work, right? I mean, and obviously not in everybody, it depends, but.
Yeah, I mean, for at least past 6-7 years, I've been doing the advanced lipid panel and using most of these type of supplements and usually getting pretty good effect. And, you know, if somebody's not high risk, meaning they don't have a calcium score over 400, you know, I'll give them a good 6 months, maybe a year to try the supplements and lifestyle changes.
You will.
And then, you know, we'll repeat some type of test in a year. And if their risk is still low, maybe we keep, you know, pushing even harder. But if at any point they become high risk or just, you know, they're taking 4 or 5 supplements, like, well, maybe it's just a bit, you know, let's consolidate and just use one agent and we'll get rid of some of that stuff then.
So I have a question here. Someone asked, what dose of berberine do you use?
So berberine, typically it's 500 milligrams twice a day.
So that's what I use in my practice as well. And I actually utilize it more for the redheaded stepchild of metformin, for any who don't want to try on metformin. You'd mentioned something else earlier about HDL not being as relevant. Now, what about, I get a lot of questions about low HDL. Is low HDL a problem? Is there a way to raise low HDL? You know, that's a question I get asked a lot.
I'm sure, and it's a good question. And the old thought was that, you know, if you had low HDL, it was a high risk factor. If you had high HDL, you know, you were never going to get a heart attack. But that really never really played out. There's been multiple trials that they've used these agents to try to raise HDL, and they almost always come out really negative. Whatever the agent that they're studying usually causes more events than not trying to do it at all. So it's never really panned out to raise HDL and lowering risk. And it's actually interesting that it's more about the functionality of the HDL. Like, does the HDL actually work? Right now, there's not, to my knowledge, a commercial lab that actually measures the HDL functionality. The best surrogate that I use so far right now is called myeloperoxidase.
Yeah.
Myeloperoxidase is an inflammatory marker that, if it's high, it tends to mean that the arteries are inflamed. But myeloperoxidase will actually inactivate HDL. So you may see it in women often. You know, premenopausal women will have high HDLs, and that's usually due to, you know, their estrogen benefit. But, you know, if you see these HDLs that are like 80, 90, you know, you look at these patients like, well, I'm heart attack proof with that. Well, you do myeloperoxidase, and the myeloperoxidase is high. It's like, well, you have high inflammation. Your body's, you know, damaging all this HDL, and your body keeps making more and more HDL to repair the damaged HDL. That's why you have high HDL. And so it's
and
not
in terms of causes of inflammation, what have you seen? I mean, everyone talks about diet, and, you know, it's really interesting. I get the individuals that come to me on a higher fat diet, on a ketogenic diet. You know, I had one case that was really, really interesting. His CRP was, I want to say it was about 5, which is higher. He had a calcium score, which was 0. His myeloperoxidase was elevated. His SED rate was elevated. And, you know, he was just very inflamed, and he was on a ketogenic diet, carnivore diet, really didn't want to change.
Sure.
Yeah. So I don't know, what do you see in terms of patients on a ketogenic style diet?
That's a really good question. And it is challenging, because I have some patients that, you know, do bulletproof diets and do complete, you know, hardcore, you know, 70-80% of the calories are coming from fat.
Yes.
You know, there's really no data in the cardiovascular world, you know, the heart benefit of it. But, you know, as a biohacker, I'm all into, you know, people can do whatever they want to themselves, but just test, don't guess. You know, if you're going to do a hardcore keto diet, then get some baseline labs first, do your intervention, and see what happens with your labs. Because I've seen some people do the keto stuff and then see cholesterol's up, you know, 350, 400, and LDL's in the 300 range. Well, they have a fat transport problem. You know, they might have an ApoE4, and then there's the people that say you probably really shouldn't be shooting for a keto type diet.
Yes.
But
did you guys hear that? That's really important. Yeah. So some people who do a very high fat diet do have issues where it doesn't actually make their blood lipids better, it makes them worse. And what Dr. Michael was saying is that it's a fat transport problem. There's probably, you know, there could be a few things, but that's certainly one of them. So not every diet works well for everyone, which I think is more and more what we're finding out. So you've seen that. And in terms of heart attack prevention, if you could give some advice, and I did get a couple questions on what's the best way to protect your heart and heart attack prevention. And actually, I also want to make a note. I do want to ask you about when people say they die, you know, the research says cardiac events or cardiac deaths. Does that include natural causes, you know, natural causes of death? from,
Most,
you know, aging? It doesn't?
most of the time not. And I mean, as you've known from like when you're in the hospital, if you're filling out a death certificate, you just pick the most proximal cause. I mean, yeah, 100% of the time your heart's going to stop when you die.
Right.
Is it the number one thing that actually takes people out? Always? Not
Right.
always. So I don't think they necessarily include, natural causes, because most trials they'll have it that it's a person died from a heart attack, heart failure, or sudden cardiac death.
Okay.
But back to your original question,
Yes.
heart attack prevention, that's, the area I really like to focus on. And, I do the kind of test, don't guess. So I typically recommend patients, if they've not had one, get a CT coronary calcium score, find out what the risk is. There's another test that I'll be bringing online soon and is available in some markets. It's just called the carotid intimal medial thickness scan, or CIMT. Yeah. It's an ultrasound of your neck artery. And it's not looking at the plaque in the artery, it's looking at the wall thickness of your artery. Your artery is supposed to be a certain thickness as you age. The thicker it is, they basically can give you a vascular age. So if your vascular age is older than your biologic age, you probably want to do something from a lifestyle supplement or med standpoint. And then I have a new toy called an endopath that actually affects your endothelial function. That's the inner lining of your blood vessels. If your endothelium gets damaged, that's the first marker of vascular disease. So I'll typically offer one of those three things, if not all three things, if somebody wants to kind of do the top level, what is my risk? And then after doing that, I go through my kind of 4 pillars. It's optimal nutrition, optimal exercise, optimal sleep, optimal stress relief. And you're the expert in proteins. I'm not gonna. I'll defer to you on that aspect of it. But my big thing I usually talk about is doing time restricted eating.
Great.
Trying to dial it into a 12-hour or less window every day. Eating seasonal, what is in your local environment. So back to the keto thing. Keto works, but keto doesn't work for everybody all over the world. It tends to be better for people who are more higher latitude. So if it's not, the vegetables and fruits aren't growing in your region that time of year, that's the time you would naturally be more ketotic. The exercise, I completely agree with you. The resistance training being the key. The more muscle mass you can take into the longer you tend to live. So, stress relief, meditation, yoga, mindfulness. I recommend the heart map device frequently for heart rate variability. And then sleep is kind of one of my area of expertise. Without pills and procedures, it's all about the controlling your light environment and your circadian rhythms. So.
All that's important. So tell me and you've really been into this biohacking sphere, right? So it's interesting. Yeah. I think that's something that you feel really passionate about. Are there, are your patients coming to wanting hormonal therapy, testosterone? I mean, I've had a lot of conflicting views from cardiologists saying, testosterone's bad for your heart. No, it's proven to be bad for your heart. I mean, I don't push them at super physiologic levels, so I haven't seen that. I'm sure that people ask you about that all the time.
For sure, and I'll break it up in 2 parts. So the hormone therapy, that is one of the things that I'm not an expert in actually administering it, but I work with many of the hormone replacement doctors in the St. Louis region, and feel comfortable co-managing patients who are on hormone therapy. And you mentioned key words, physiologic. If your blood levels are kept in physiologic ranges, I don't have any concern with it. It's more the guys using testosterone, quote, over the counter that we tend to see the problems. They got these super, gorilla, level of testosterone. And from a heart standpoint, essentially just increases the hemoglobin, the substance that carries oxygen around the system. And I tell patients your blood starts to be more like ketchup. It gets really sticky. And that's just more risk that blood clots form when you have too much hemoglobin. So I will routinely check for their hemoglobin levels and their ferritin, their iron levels when people are on testosterone therapy. So as long as their testosterone levels aren't extremely high and their hemoglobin levels are normal range, I don't have an issue with patients being on testosterone therapy. But I will work with them to figure out if there's a proximal reason why do they have underactive hormone function. So
listen, I'm telling you, you could be lifting hard and sleeping well, and I mean, this is just what I've seen. And no matter what, some guys hit their 40s and their testosterone.
Right.
We can try everything. You can give them zinc, you can give them boron, you can have them sleep, you can get them a CPAP machine, But at some point, the threshold for suffering is low, and you try them on testosterone, and they do amazing. And I think that's important to point out, that sometimes the severity of the illness or the severity of the situation has to match the severity of treatment,
So for sure.
I would say that, we definitely don't believe in people suffering. And let's got a question on those people that are on statins that do feel like they're getting pain or having issues with tendon and muscle. What do you recommend that they do?
So first I'll figure out which statin you're actually on, because I tend to see that the simvastatin Zocor or the atorvastatin Lipitor tend to be the worst causes of those things. Second is kind of the dosage. If you're on very high dose, make sure you need to be on the high dose statin. If you have a high, you've had stent bypass, high calcium score, maybe you're going to need to be on higher doses. But some of the things you can do to help mitigate some of the muscle pains is CoQ10 can help with that.
And what dose of CoQ10 do you usually recommend? Is it based on age?
It's not necessarily age-based, but I will check a blood level, and starter dose at least 100 milligrams, but more likely it's going to be 300.
Yeah.
Rough rule of thumb is 100 milligrams of CoQ10 for every medication that can deplete CoQ10, and that includes beta blockers, which I don't always know if everybody realizes that being on metoprolol and such is going to lower your CoQ10. So if somebody's on metoprolol and a statin, they'll tend to use at least 300 milligrams. But then, like I talked about earlier, is making sure your thyroid's fully optimized, making sure you're not vitamin D deficient. It's almost every single person we ever see has vitamin D deficiency. They almost all will have some type of muscle ache. Or they might not have the classic muscle aches with statins, but they'll just notice that they don't have as much power when they're at the gym.
Yes, I totally agree with that. So someone said, does thermography scan show carotid arteries? If they're warm, should they get a scan?
It's a good question. I don't know the data.
I don't either.
A lot about it, but I've had one patient get a thermography for breast health, and they said her carotid was lit up. So I did like a CMT and a calcium scan, and her score was mildly high, but it didn't 100% correlate. But thermography should show that there's some type of inflammation in your system. You got to go find the root cause of what's causing that inflammation.
So tell me where people can find you and what kind of, if you're accepting new patients, how you do your practice. I'm sure people would really love to know that.
Sure. So I'm located in St. Louis, Missouri. I have a practice here. It's called Apollo Cardiology. And then I also
And that's in Clayton, right?
Yep, it's in Clayton, downtown Clayton. So centrally located in St. Louis, 10 minutes from the airport. So if you want to fly in here and see me, I'd be happy to see you. And then I do offer telemedicine visits. I would like to see patients at least once a year physically in the office, and then follow up over Zoom, and we can go over labs or any type of testing. I'm most active on social, on Instagram here, just Dr. Twyman. Those are probably the best two ways to get a hold of me, is apollocardiology.com and the Instagram.
So that's a really good point. So that's how it is for my clinic. Most of my patients come in to see me one time a year. Depends. I don't know. I've got good relationships with them. Sometimes they'll come more. You know who you are. But they come from all over the country. So if you guys want to see a great cardiologist, fly down to St. Louis, see him, and then you can be followed with him. He'll follow you for the year, and then once a year you go and see him, and you'll be getting great care, and it's worth the trip. Make it, go to the museum, go listen to a lecture at WashU, kind of make a little trip out of it. But it's definitely worthwhile when you find a practitioner that you align with and is very well educated. It's worth it. So that's my advice. And all my patients, by the way, especially the patients that are going on hormone therapy, I always send them to a cardiologist.
Yeah, it's a good idea. And then just get screened, make sure they don't have high blood pressure in their lungs, they don't have sleep apnea, and then they're good to go.
That's right. Well, thanks so much. And I'm sure we're going to get a ton of questions. So you guys, please go follow him. I'm sure you have questions for him, and he's going to do his own live, and I'll come on his. So
well, thank you very much, Dr. Lyon. This was great.
Yeah. Thanks so much. Bye.
You guys have a good day.